Now, we introduce tonight's moderator, AANA past president, Dr. Lewis McIntyre of Northwell Health. Dr. McIntyre?
Thanks, Kim. Well, thanks everybody for joining us this evening. We'd rather be watching a baseball game or something else, but we are here because we're in the midst of an unprecedented pandemic that has really disrupted our practices. And this webinar is meant to disseminate useful information concerning the response to that disruption from a very practical practice management standpoint. It will be posted on the website for all those unable to attend tonight, and also if you need to get up and go get a cold drink or something. So we're really lucky tonight to have with us the AANA leadership from a diverse geographic and practice paradigm standpoint to get a rather comprehensive look at how some of the most successful practices in the country have handled this crisis. Our opinions here are meant only for the benefit of our members and all of the orthopedic surgeons in the country. AANA's not really endorsing any of the views expressed here as an organization, so please, before implementing any of these strategies, consult your practice legal and accounting professionals. I'd really like to thank our AANA staff for getting this webinar up and running in 3 days. So thanks to Kim Santinello, Matt McNutt, Adam Foltz, Robert Keiss, and of course our CEO, Laura Downs. So now let's get to our panel. Tonight we have with us a star-studded group of experts in this realm. First, we have Brian Cole, managing partner at Midwest Orthopaedics at Rush, and he's the first vice president of AANA and will take over the presidency next month. We have Mark Gettleman from SCOE, the Southern California Orthopedic Institute. He's the second VP of AANA and will be the first VP as of May. We have Jim Stone of the Orthopedic Institute of Wisconsin, who's AANA's treasurer, and Eric Steeple of Valdosta Orthopedic Associates in Southern Georgia, who's our advocate chairman who works on behalf of all the orthopedic surgeons and arthroscopists in the country in the advocacy arena. And lastly, we have Nick Scaglione, who's the chair and senior vice president of the orthopedic service line of Northwell Health, which is the largest healthcare system in New York State. He's also the AANA chair of the AANA trustees and of the Education Foundation, and he's also a past president of AANA. So for tonight's format, each panelist is going to give a 5-minute synopsis of the key things that they've been doing in response to the challenges that the coronavirus pandemic has presented to their practice. Following that, we're going to go to some questions for the panelists, and I would encourage everyone to use the text function of the WebEx platform to submit questions, and we will get to them. So with that, I'd like to introduce my good friend and the first vice president of AANA, Brian Cole, and he's going to describe what they're doing at Rush in response to the coronavirus pandemic. Brian.
Good evening, Lou, and thank you. And I took the liberty to take a few notes just to be concise and do my best to disseminate some information that I think would be helpful. On Monday, during our board call, we all recognized how much we actually learned from each other in the usual and customary ways. So, back in January, February, we were teaching each other about surgical procedures and decision-making, and now we're concerned about what tomorrow will bring. And that's really the subject of this webinar. So it's really to help everyone manage and emerge on the other side here to remain viable. So I'll tell you a little bit about my situation. I'm Brian Cole. I'm in Chicago. I'm at Midwest Orthopaedics at Rush. I'm the managing partner of a 35-year-old practice at Midwest Orthopaedics at Rush. It's a private academic group. Our gross receipts, absent of surgery centers, are about $125 million a year. It's been growing at about a 5 to 10% clip. We have approximately 30 partners, 15 employed physicians, 50 to 70 advanced practice practitioners, 9 physical therapy locations, 7 ASCs, 5 MRI scanners, about 500 employees, and an academic facility known as Rush that is now one of the 35 designated COVID centers right next door. On March 17th, due to the risk of overwhelming the hospital system and the inexorable need to adhere to all the aspects of social distancing, all non-essential activities were requested to cease. In many ways, our new S&P is what's happening at the hospital, and that's how I think about it, because all of our functionality and what we do today is really predicated on the ability for us to prevent the hospital system from being overwhelmed and to keep it sustained. And then everything else follows suit. So when we recognized the immediate discontinuation of elective procedures, that's when we basically instinctively looked at all available cash, and that's kind of when reality struck. We thought about projections, the timeline, knowing that the way it shut off would not likely be the same way it will turn back on. There will be reduced need, unemployment, the lack of healthcare benefits. There's going to be an unwillingness to undergo elective surgery. And there's a prediction that we made the prediction that we'll be at about 60 to 70% capacity for some time. And then we made assumptions. We assumed that January, February, and March revenues will still continue to come in, but April revenues will decline by about 50%. And we're not expecting any meaningful revenues between May, June, and July. We think they may be close to zero. If we are lucky enough to start real clinical activity by July, there will be no real revenues based upon a 2-month lag between August and September. And that's assuming the payers actually do their job on the other side. We're trying to maintain an environment where we can flex back up with no remaining cash to pay for the workforce and the potential for payers to come online slowly, further elevating this financial situation. So what we did to reconfigure our 35-year-old business model is as follows. We first looked at the revenue side because we said, look, if we could maintain a trickle and do our business and actually provide care to patients in a meaningful way while observing all of the issues, we trained 100 providers on telemedicine. Prior to that, we had 2 in our practice that utilized telemedicine. We did that in 48 hours. We currently use a program called Chiron. It interfaces with Athena. When it doesn't work, it crashes or is inefficient, we use FaceTime, we use email, we use the telephone, and we still use some of the coding issues that you're going to hear here presented by Eric Steeple. We created several forward-facing documents of how we'll practice medicine. We addressed everything from telemedicine. We maintained enough MRI, X-ray, PT, et cetera, to service the urgent evaluation is determined by the telemedicine needs. We will provide office visits only if further examination is required to determine anything that's time-sensitive or urgent, apart from something that can be treated with benign neglect for now versus what might require immediate intervention. We also separately address, because we have a large work comp population in Chicago, it's about 30% of our practice, it's our greatest payer mix, so we have special sensitivity to that, and we have several forward-facing and direct email outreach to our work comp population. It's a very high value for us. We also evolved our screening processes to assure that the staff and the patients are safe. It includes pre-screening, temperature checks, and everyone is masking on both sides now. Then we attacked our expenses. We took about a $7 to $10 million monthly run rate down to a $2 to $3 million run rate by deferring, abating, furloughing, and we did a line-by-line analysis of our entire business. Our overall premise is that we're trying to preserve enough cash to ensure solvency through a ramp-up that will probably not be better than 60 to 70% for the better part of a year. What we did is we went back to 2019 and we looked at the revenue numbers. And in order to see how we're going to pay people and make revenue estimates against our expenses, we said, let's say that 2020 will be about 60% of 2019. We're keeping our eyes on emerging as a leaner, more efficient practice, perhaps with less bricks and mortar, utilizing more telemedicine. We know there'll be dramatic consolidation and there'll be further centralization of our services. So specifically, finishing up what we did, we reduced our clinic operations from 7 to 2 sites for essential care only. We closed 5 of our 7 ASCs. As a full distribution LLC, we have no meaningful reserves. All partners have agreed to essentially a neutral capital balance, basically placing a cap on each partner's debt to about $300,000. That's about how far negative we will let them go, and then we're going to talk about ways to recoup that. We went to real-time cost accounting now, month by month, to avoid individual debt accumulation. So the partners have full control over their direct expenses, and we assign every month their direct expenses and their indirect expenses to that partner. And then whatever revenue they get, if they're plus or minus, that determines their capital balance. We will watch them month by month to make sure no one accumulates significant debt. All of our employed docs were asked to take a de minimis salary. We've deferred all of our rent and increased our credit line substantially. We're going back to our banks that we have relationships with. On the rent side, what we've done that's worked very well is we've added lease time at the other side of the lease and actually got a full abatement for 3 to 6 months in some instances. We've prioritized all our debt associated with any covenants and personal liability. So there's not all debt cannot be put off or deferred. So you have to be very careful about which debt you decide to do that with. We have applied a day one for the 7A loan, the PPP program. as a priority, and there's indications already that there's not going to be enough money to go around. All of our planning is done in the environment we will assume we will get nothing from the government. We're making no assumptions that anything will come from the government, even though we're applying for everything available that you're going to hear about. We applied for the Medicare payment advances, and we expect to have that by next week, but who knows? We've deferred all payroll taxes, vendor payments. We've eliminated any spend that would not compromise our business operations today on the supply side. Every single line item was touched, including medical malpractice, rent, marketing, line reputation management, our PRO tools. We basically looked under the hood to find any and all expenses that we could either defer, abate, and pay later. With our employees, we furloughed about 75% of our payroll. We're maintaining their benefits. We're allowing them to use 1 week of PTO. Some practices are using all weeks of PTO. That is a huge economic burden. They need to come back and have some PTO in place when they're done. It's basically a situation now where the unemployment benefits are very, very generous, about $452 a week plus $600 per week. So it's important that you don't basically put yourself in too much debt by you got to be fair, keep the morale up. We're giving them healthcare benefits for the foreseeable future, but keep in mind that the government is picking up a lot of this unemployment side. So be careful about paying or giving away PTO. And finally, now that the fire drill is over and we've complete reset, we believe we're poised and ready to resume activities as long as we know we won't compromise the needed hospital resources going forward. That is our priority. We will continue to practice rigid social distancing. When the curve tips, we think we'll expand the lift of operations responsibly, but always with the mindset that we must maintain the health of our staff and our employees. Thank you for your time and attention.
Thanks, Brian. Boy, that was a great synopsis on crisis management and words to heed. Now we're going to go out to the West Coast to Mark Gelman, and he's going to tell us what SCOE has been doing over the last 2.5 weeks to mitigate this challenge.
Thank you, Lou. Thanks, Brian. And I don't want to be redundant, and so we're going to basically just continue some of these concepts and some of the things that we're talking about. Like Brian, we are a large group. We have 7 clinics. We have almost 500 employees as well. I have 5 physical therapy centers, 4 ASCs, and we have a lot of employees as well. We are a private practice, privatemic group as well, who have an affiliation with UCLA Health on the last year, which has been a very good relationship with us. And so like Brian, we are doing a lot of the same things. Because we are not a foundation, we are a private entity, or a private LLC, we had to go in and internalize and do all this ourselves as well. So the biggest issue was, number one, looking at cash flow. We knew what we had in the bank. We know, just like Brian, we're going to continue to get our revenues for the next 3 months, but we anticipate a significant downturn in the next few months. And so in order to maximize our cash flow, we have looked at all our expenses as well in a similar fashion. We have spoken with our bank, we've spoken with our accountant, and we've spoken with our labor attorney, all of which are helping us to do the right thing by our employees, by our partners, and by the state, which has put a big mandate on us. California, although we are behind the curve of New York, Louisiana, and certainly Illinois right now, I think our state has actually been the most proactive, and we were the first state to go safer at home. And so we have been at home probably longer than anybody, ahead of New York and ahead of the other states. And so that is going to place a longer period of time on us where our revenues are going to be down. Human resources is obviously a big issue, and we have tried to do what we can to help with that process. And we have been very conscious of continuing to have our employees for the time being. And we are trying now to look at ways to basically be able to keep our employees, furloughing those who can potentially be furloughed, but trying to keep people employed, as I think that's going to be a big part of the 7A PPP as we move forward. In terms of our practice, we are currently keeping almost everything up and running still. We are reducing the hours in the clinics that are available, and we still have a large number of patients who are coming in. A lot of them are the work comp, as Brian talked about. Our practice is about 20% work comp, and we also have a large population of people who speak other languages, and so they have interpreters, and that's been a bit of a challenge for us. We are trying to do everything that we can to maintain social distancing, and everything we say each time is safety first. So we have a full team run by our primary care sports doctors who are really involved with the COVID analysis. And we literally every single day make changes in our protocol. We have a full page questionnaire about any symptomatology. We then do 2 temperature checks, and the patients are all washing their hands or using hand sanitizer when they come in, as we are as well, using gloves, masks, and making sure we're trying to be as careful as possible and trying to only see what is urgent or emergent. We have shut down one of our surgery centers completely. We have reduced the capacity of our other 3 surgery centers to about 50% time. And we have a triumvirate of physicians who is reviewing each case to determine what is truly urgent and emergent so that we are doing the right thing by our patients, but we are also protecting the resources as they are necessary throughout the state. Because we are independent, our surgery centers are independent, so we don't have the restrictions that Brian placed upon him from the university. And so we are trying to be careful and cognizant of that as well. We are planning to access the federal assistance program through CARES with the PPP, and we've already spoken with our banker and are hoping to be one of the first in line to get that loan that we can apply for as of tomorrow. From a partner's compensation point of view, we have also recognized that it's important to keep cash on hand, and we are doing what we can to reduce our draws so that we have cash in the bank to be able to handle this. And we are working to be sure with our consultants and our labor attorney and HR to make sure we are keeping our employees in the best positions they can be. Telehealth for us was very quick. We are an Epic practice, and Epic does a very good job, I think, in terms of employing telehealth. We were up to speed in 72 hours, and we are now seeing over 600 visits a week on telehealth. And so I think that's going to be a big part of our practice as we move forward. As we understand, the ramp up and the ramp down are going to be different, and it's going to be important for us to maintain cash on hand so we're in a good position as we continue to move forward. But our primary goal right now has been safety first, safety for our patients, safety for our employees, and we're trying to do what we can to try to keep patients out of the emergency rooms, out of urgent care centers, to protect the patient's health and to do our part for the state of California as well. Thank you.
Mark, that was great too. So now on to Jim Stone, who's in Wisconsin, and Jim also has a physician-owned hospital, which puts another twist into his management of this crisis. Jim.
Thank you, Lou, and thanks everybody for attending. I hope everybody's well, along with all your families in this difficult time. Just to give you an idea, we are in Milwaukee, Wisconsin, which is a smaller market. You know, Milwaukee and its metropolitan area is about 1 million people. We're a 17 physician orthopedic group with 2 of our docs on their first year who are salaried. We have in our group 19 PAs and nurse practitioners and about a total of 125 employees. Those, of course, include front desk, MAs, X-ray, et cetera. We do not have in-house anymore coding and billing that we farmed out to McKesson a few years ago, and our call center scheduling is farmed out. Milwaukee and the suburbs, again, smaller area, currently has about 1,085 cases of COVID as of today, and that's about 2/3 of the cases in the entire state of Wisconsin. Giving a little bit more idea of our practice, in addition to our physician practices, 7 of the docs are invested in a surgery center, 3 of the docs are invested in another surgery center, and 15 of us are invested in an orthopedic hospital, which is 50% owned by doctors, and 50% by Ascension Healthcare. From a ancillary point of view, we really have minimal at this point. We used to have physical therapy and an extremity magnet, and neither of which we have anymore. The PT was sold off. So on March 19th, when things started to hit the fan, that was when we cut our office, similarly to what you heard from Brian and Mark, to just post-ops, urgent visits, patients in the middle of their injection series. And we use similar screening techniques with historical techniques, checking for symptoms and exposures and taking temperatures. We do not currently mask in the office, nor do we mask our patients. I suspect that is going to be changing given what's been going on today with some of the newer CDC recommendations, which are rumored to be coming out. We have now extended these same restrictions in our office until May 1st at this point, and it's being reevaluated on a weekly basis. We too have instituted telemedicine, which was really no one was doing up until this, and now basically all the providers are doing it, and we're using a platform called doxy.me. We do not have Epic. We have a EMR called Prima. From the standpoint of payroll, when this again first hit the fan, we were right at the end of a pay period. We made the decision for the next 2 weeks to fully employ all of our employees, regardless of how much they worked, going up through the 1st of April. We are continuing to do that at this point. We are applying for the PPP loan, which will hopefully be the forgiven type, and our intent is to keep our staff employed and covered for the next 8 weeks. Of course, that'll have to be reevaluated depending on how efficient the government is with approving and getting those loans out. The physicians themselves are adjusting their pay downward as appropriate. We operate similar, what sounds like, to what Brian does, and basically each physician is able to adjust his salary based on receipts, direct and indirect expenses. In addition, just like you have heard, we will almost certainly take advantage of the CMS Medicare payment advance to help smooth out cash flow. And I think it's important for everybody. Every practice has to have a line of credit in place because almost everybody is going to need to use it. Our practice manager is in the process of doing an appropriate cash flow analysis, just like Brian and Mark were also talking about, using historical assumptions regarding accounts receivable and gradual ramp up of the office, as has already been discussed. Lou asked me to just specifically discuss some of the issues regarding the orthopedic hospital. We're in a little bit of an unusual both physical and financial position. Physically, we're a hospital within a hospital encompassing the second floor of a 5-story building. It's a small community type hospital. We have 6 inpatient beds and 6 operating rooms. On March 17th, we voluntarily restricted to elective cases only to patients who were in extremely good health. And we had very strict criteria. It really eliminated about 80% of our patients. And this was rapidly changed based on what was going on in Wisconsin. We basically stopped all elective surgery on the 19th. Our employees are actually leased employees from Ascension Hospital System. And that's a little bit of a win and a little bit of a loss. The win is that they can be farmed out to other parts of the Ascension Hospital System so that they won't necessarily need to be laid off if we're down for a long time. Though the true loser is that since they're not part of our employees directly, we can't get PPP at the hospital. One of the ways we're trying to mitigate the lack of use of the hospital, however, is that the non-orthopedic hospital in the building is, as I said, small community. It's only got 36 med-surg beds and 16 ICU beds. Currently, they're using 7 out of their 9 ventilators. I do not know if they're all on COVID patients. And what we will be is basically a surge hospital so that the orthopedic hospital and its 60 beds will be used for non-COVID medical or surgical patients to be housed on our floor. And they may even elect to use our hospital as an isolated area to keep, to do surgeries both on orthopedic patients that have to be done and surgery patients and keep them away from the potential COVID population. Again, we can't take advantage of the PPP. We know that there's going to be a cash flow crunch ahead in the next 2 to 3 months. Therefore, in this and our surgery centers, we're anticipating no distributions to owners for the next 2 quarters to ride this out. So that is my summary, Louis.
Well, thank you very much, Jim. And now we'll move on to Eric Steeple, who's down in Southern Georgia. Eric.
Hey, Lou. Thank you. So a little summary about Valdosta Orthopedic Associates. It's a smaller rural practice. We have 90 employees. There's 10 orthopedic partners. We have 3 mid-levels and 2 pain management doctors that are salaried. We do have ancillaries that include ASC, MRI, physical therapy, DME, and pharmacy. Beginning about 3 weeks ago, we started to notice a decrease in patient volumes. And on March 18th, our local hospital canceled elective surgeries and our ASC followed suit. So we're still doing acute injury and fracture care, but there's no elective arthroscopies or total joint procedures. The community that we service has a metro area of about 140,000. It's a single hospital system, South Georgia Medical Center, which has 400 beds. The COVID burden as of today, there's 50 confirmed positive cases in our county, 30 that are hospitalized, and there's been a single death. So to date, the disease impact has been relatively minimal. The financial impact to our practice, however, has not been. So one of the ways that we're measuring potential revenue decreases is we're using volume as a surrogate and looking at the volumes of all of our ancillaries. MRIs down 15%, PT, and this is over a 2-week period. Physical therapy visits are down 50%. ASC scheduled surgeries are down 80%. Surgeons' fees are down 70%. Office visits 35. So we combined these numbers and looked at their relative weight compared to our take-home income, or collections rather. And what we're seeing is we're projecting a 50% decrease in total revenues for the last 2 weeks. This issue has been compounded by the fact that we're noticing that the payers are beginning to delay their reimbursements. So as has been mentioned several times, the general plan for our office, we have implemented staff and patient screenings. We're strict adherence to the recommendations on hand washing and cleaning. Our HR has been referring patients that have had diminished hours to the unemployment office for unemployment benefits. The state of Georgia has actually increased the dollar amount for eligibility. So a lot of our employees now that have had decreased hours are eligible for unemployment benefits, and we're facilitating that. The office has implemented telemedicine. As was mentioned previously, we've also restricted PTO. We've restructured our office hours, so each provider is doing a half a day of a clinic. The ASC is open 2 days a week for these urgent cases. Our plan for April and May, we're going to apply for the SBA loan. The eligible amount for our business is around $1 million, and this would cover 90% of our expenses for the 8 weeks. We're going to pass on the employment retention tax credit. I think you have to pick one or the other of these, and the SBA forgivable loan, the 7A loan, was a greater dollar amount, so we're going to be applying for that. We will be using the family leave and sick leave tax credits. If we continue to have a volume issue in May, that's when we're going to apply for the Medicare advance payment. The one thing about the Medicare advance payment, the biggest positive is the turnaround is very short. So you receive a determination on your application in 7 days. And so we have not pulled the trigger on that yet. But this would cover, this plan would basically cover our expenses through September if we're able to secure this forgivable loan. And I can get into some additional details about cash flow later.
Great, Eric. Thank you very much. And now, last but certainly not least, is Nick Scaglione, who runs the orthopedic department at Northwell Health, which is the largest private employer in the state of New York with about 64,000 employees. It is ground zero for the COVID virus pandemic in New York right now. So here's my dear friend, Nick Scaglione.
Thanks, Lou, and greetings, everyone. Good evening. Greetings are from New York City. We are the current epicenter of this pandemic, and I would say to you, as Lou pointed out, Northwell Health is the epicenter of the epicenter. This is related to our geographic footprint. So Northwell Health is 23 hospitals across the entire New York metropolitan area, so the entire downstate area, all of Long Island, from Manhattan to the Hamptons. We have about 5,000 beds in these 23 hospitals. Our department, our orthopedic department, includes 126 full-time orthopedists. That's in 33 offices, just the full-time department. And that's in addition to our over 120 loyal voluntary physicians that operate at our hospitals. So it's a large-scale operation. That operation is being bombarded by the case volume. As you know, that the case volume, which is now increasing across this country, as of today, is estimated at 216,000. The case volume of COVID positive patients is 84,000 in New York State and 45,000 in New York City. And just in our boroughs around New York City, we're seeing everywhere between 10 and 15,000 cases. We are getting 200 to 300 on average admissions a day into our hospitals. And today that number was 141, and there was somewhat of a sigh of relief as one data point on the plot that we're carefully watching to see when the peak will happen. There's been some really smart people looking at predictive modeling in the New York region based on other countries and based on math. And the sense is that the peak may not occur until possibly April 14th. We have right now 2,500 COVID positive patients in those 5,000 beds. 28% are in unit beds, and about 25% are on vents. So the dramatic numbers you're seeing in the news and so on are what we are living every day. I operate at 2 of the tertiary hospitals in our system, and of those 2 tertiary hospitals, we have 1,500 patients in our beds. So we are effectively shut down except for emergent cases. And so we're doing traumas, et cetera. Our ASC that I operate in has been turned into a postpartum recovery unit for our healthy, segregated postpartum patients. And a number of our other ASCs have been turned into COVID patient units. We have a total of 14 ASCs across the system. So I think the problem we have is not only scaling back, but the fact that we are preoccupied with taking care of really sick patients. We had begun very early, a little bit earlier, and so on March 7th, we essentially shut down all elective surgeries in orthopedics, and this has been adjudicated by a surgery committee. And I will tell you, we're backlogged 1,600 ortho cases that we have not done over just 3 weeks. And I will also share with you that we are down 10,000 other surgery cases across this system. So the magnitude of disruption of healthcare relative to just surgery is quite significant. Now, I appreciate Lou's giving the opportunity for me to share this information. I do believe, although New York City and New York State are bearing the brunt of this pandemic at this time, I am concerned about other parts of this country relative to the curve and relative to what we're seeing. Almost, I think, what we had viewed as what was happening in China, and then what we saw, what was happening in Italy, and now what we see is happening in New York. I'm concerned about New Orleans. I'm concerned about other cities. I think there are lessons to share with all of you about what we have learned, some mistakes we have made, and what we're trying to avoid. And I will comment on a few of those things. I think there is an unprecedented short-term disruption, but I will share with you that we began 3 weeks ago with emergency management teams looking at what the recovery will be when the recovery needs to occur. And I am on daily emergency operations center team calls, as well as round-the-clock ortho service line calls and huddles. So a lot of this is important. Now, what I would say is what is key for all, if things start to heat up, is communication. And so part of, I think, tonight's effort on the part of Lou and my colleagues, as well as the Arthroscopy Association, is to begin with communication. And I will share with you that one thing that we see in assembling our teams is to be able to reduce anxiety with information and to share best practices. So what we've set up is an ortho clinical leadership team. This is just within our service line, ortho administrative team. Key to this, when you heard my colleagues talk about telehealth services, is we have an internal IT team that's helping us not only with telehealth services, but really what we started to do, which is in some cases have remote team meetings, which we do several times a day. And I've never used Microsoft Teams as much as we've used it in the last 3 weeks. We also have been involved in some redeployment efforts, and so we have a total of 50 residents and fellows, and so they are being redeployed, and I think resident and fellow education has to be sustained, and that's where our program directors are on our emergency management teams to work with us carefully in terms of taking care of our trainees. Lastly, we have internal, separate from our larger finance team, we have internal finance experts that are trying to model out the financial disruption to produce some predictions and I think bake that into our recovery efforts. So a few takeaways. Again, I don't think you can over communicate when you have a crisis that is essentially so fluid that it's changing by the day, and when anxiety is high, particularly with your staff. I think we manage up and we manage down. So I'm on some of the command center calls, and then we are trying to disseminate that information to staff, our PAs, our nurse practitioners, our physicians, and our ancillary staff. We use Microsoft Teams as a remote telecommunication platform. I think you heard a little bit about safety. I would caution, I think a lot of you may know about N95 counterfeit masks and cold calls that come in, particularly to our procurement and our supply chain people, people who want to sell the health system and others and large groups N95 mask and protective equipment. We do ask and mask all the patients coming in, but I will tell you we've run out of masks. So we're masking all the staff, and we're using thermometer guns on the patients coming in addition to the ask and mask. I think that with adoption of the teleservices earlier on, I think that's ramping up. We do use American Well as the platform, and our EHR is Allscripts. I will talk a little bit about redeployment. There was a question about that. We have already redeployed 10 orthopedic surgeons to help on medical units. That's how bad it is here. And we've redeployed 35 residents and fellows and 40 PAs. So I think in the heat of this battle and in the hot zone, we have had no choice but to try to help out. It started with low acuity EDs that were set up in tents, almost like urgent centers. And now we have orthopedic surgeons in the actual hospitals. I'm going to finish by talking a little bit, and I think there'll be some measurements about something that I've been paying attention to, and that is recovery. We do know that the battle is being fought right now and will continue to be fought relative to healthcare. But I do want to urge everyone, and I think the spirit of tonight is to understand what recovery and restarting the engine should look like. We are compiling all surgical cases that are canceled and postponed. We are keeping logs of that. We're engaging those patients. We have a team that just looks at that. We are stratifying them according to the American College of Surgeons, level 1 through level 4 prioritization. So level 1 are emergent. We're doing them now. Fractures. Level 2 are urgent. They need to be done within 4 weeks. Level 3 are semi-urgent. They need to be done in 3 months. Some total joints, some spine. And level 4 are patients that you can postpone beyond 6 months. I will point out to everyone that I do not believe in the term elective surgery. And I would submit that there are patients who we may think are elective orthopedic patients, such as an ACL or a total knee that needs to be done. But the impact on these patients from a healthcare standpoint can be substantial. And I think we need to be advocates for them in terms of restarting the engine with this backlog, particularly when it's related to other surgical subspecialties. So I think the silver linings playbook that I will tell you about that we're looking at is we are going to have to deal with a new order. We are going to have to deal with what medicine and tomorrow looks like. And the areas that we're concentrating on is understanding new and innovative models of patient access that go beyond teleservices and patient engagement. I think it's going to go on. It's going to have to do with what patients demand. In the next year, a number of elective patients, using the elective word, are going to have anxiety about getting things done. Think about it. And so we're going to have to address that in terms of perhaps segregating certain centers that are COVID-free to be able to ensure safety. We are going to be looking at testing all patients preoperatively in a pre-admission testing setting within 24 hours of rapid testing for the patient's safety, but also for the healthcare team and the operating room team safety. We're looking at continuing to advance, moving to the outpatient space, more and more orthopedics, and I think we're going to see that as a trend that takes off more than we've seen over the last 5 years, and designating some of our 23 hospitals as designated subspecialty orthopedic hospitals, perhaps with regionalization. So what I would maybe summarize and finish up with is it is certainly a fight here in New York, but we are, I think, as they say, the saying is, we're looking at the rainbow and the chaos. And I think that we all must share our plans to be able to get through this and to be able to successfully restart the engine. So I appreciate the time, Lou, and others given to be able to do this. So thank you very much.
Thanks a lot, Nick. A sobering analysis, but hopeful nonetheless. We know that eventually we'll be ramping up, and I think that's one of the most important things to consider is as we manage our acute crisis to always remember that this will pass and that we need to design our ramp ups as well as our ramp downs. So that's an excellent point. There are a lot of questions coming in on the Paycheck Protection Program and telehealth. So what I'd like to do now is shift gears, and Kim, if you could pull up the slide deck that Eric has on those two issues, and Eric, if you could run these through the nuts and bolts of some of the programs that the federal government has instituted with the coronavirus bill that was passed, the Aid, Relief, and Economic Security Act that was signed by the president on Friday, and also some of the nuts and bolts on how you actually bill for telehealth services.
Sure. I guess the first section, loan forgiveness programs that are available with the new legislation. If we could go next slide, please. So these are fairly detailed slides. I would go back 2 slides, please. Is that the first slide? Okay. Forward 1, please. Okay. Lou, can you still hear me?
Yes, you're on.
All right. I had a big glitch. So these are fairly detailed slides. At the bottom of each slide is a reference link to the primary resource. So this is directly from either the government website or the IRS. But beginning with the COVID-19 Economic Injury Disaster Loan, or this is the Paycheck Protection Program or the PPP. So the program loan application date actually opens up Friday. So our group has completed our application. It is in the hand of eligible businesses or businesses with less than 500 employees. The forgiveness period, so essentially you will forgive.
If you could go over that again, Eric, you broke up a little bit. Lost Eric for a second, so while he's getting back up, I'll ask Nick a question. There's some questions coming in. Nick, how are you going to manage resident education while this is going on? There's no cases. They're being resurfaced. They're repurposed to doing other things.
Lou, can you hear me?
Yeah, we're just going to just ask Nick a question. You can jump right back in a second.
Okay, sorry.
Yeah, so what we've done is we've implemented using Zoom a regular conference. So from a didactic educational standpoint, we are paying attention to this very carefully. From a surgical case log standpoint, this is a disaster. And we don't have a good plan in place to recover. Obviously, those that are graduating, it's a different situation. Those that are coming through are going to be, we're going to have a redeployment relative to those cases that are going to be made up. I think this is something we have to pay close attention to as far as case logs. There
Has
is
the ACGME, have they been discussing this at all or no?
We haven't been discussing the case logs yet, but they will be. And I can tell you that, there's been a lot of back and forth relative to, we have medical students as well in third year versus fourth year. So there's, from a trainee standpoint, at every level, this is going to have impact. And it's something that we're going to have to pay attention to as part of the recovery.
Thank you. Eric, let's see if we can get you going again.
Okay, I'm hearing you very well. So the first program we were talking about, PPP. So this is a very valuable program. The application date opens up Friday and runs through June 30th. Eligible businesses are those with less than 500 employees, and essentially this is a loan that you get with your preferred lender, and then in the 8 weeks following securement of the loan, the federal government will give you a grant to forgive certain portions of the loan expenses. These expenses include payroll costs, employee benefits, leave, debt refinancing, and rent and utilities. Some of the caveats to use of this loan are 75% of the forgiven amount has to be used on your. You also have to maintain your payroll at 75% of its historic amounts. The loan amount is calculated by looking at the average monthly payroll multiplied by a factor of 2.5, and and then the forgiven amount is based on your employees maintaining their position, or you maintaining your number of FTEs, or your company quickly rehiring employees that have been furloughed. Next slide, please. The alternative to this program is the COVID-19 tax credit. This is the employee sick leave credit. So this is eligible for all employees. So you can participate in the PPP program, and you can participate in the eligible sick leave credits. So all employers are eligible for this, and essentially you receive a dollar-for-dollar credit on sick leave up to 80 hours per employee that is sick due to issues related to the COVID pandemic. This also includes family leave for childcare, and the family leave is paid at 2/3 regular pay up to 10 weeks or $10,000 for an employee. Next slide.
Eric, I think we lost Eric again. So I'll go to some questions. Mark.
Yes, sir.
Are you advertising your telehealth capabilities at all?
So yes, we are. So we are using our SCOE website. We're also using social media, and we are making sure all our patients know that this is an availability for them. And we're actually trying to encourage them. We are working with UCLA and Epic to try to make this as easy as possible. It is a little bit challenging for those people who are technically not super savvy on the front end. They have to learn how to set up their app on their phone so that we can do this. The government has made modifications to HIPAA right now, so you can use other platforms such as FaceTime or Zoom. But as we move forward from this, we're doing it in a HIPAA compliant way through Epic, which has been working very well for us thus far.
And do you think that this is something you're going to incorporate into your practice moving forward after this is after we're through this acute period?
Yes, absolutely. I think that this has become a real positive. One of the big challenges, for instance, for me, is MRI reviews. It's very difficult to find the time, and when you spend a lot of time in the evening doing MRI reviews with patients on the phone, you're not getting reimbursed. And so it's a real challenge. The patient can't see the images and see what's going on. With telehealth, I can actually use my iPad or my phone to show the patients the images, have a conversation with them. And most importantly, if you understand what you're doing and you take a comprehensive history you document your physical examination, and you have medical decision making of an appropriate level, you are billing this as a standard recheck appointment with a telehealth modifier. And so you're actually doing the same thing as being in the office. So this is a great avenue for all of us to be able to do some things that will allow us to be more efficient when we're done with this using this platform.
Great, thanks. Eric, I think we have you back again. You want to try? Let's try this again.
Hey, I'm back on. It seems like this is happening just when the slides are changing. Move forward. I think we were on the sick leave tax credit.
I think the next one.
Okay, one more. So the employee sick leave, everyone should take advantage of the employee sick leave tax credits as members. The employee retention tax credit is an alternative to the PPP program. This is for employers with less than 100 employees, and it's not available to those that are receiving assistance through the Paycheck Protection Program. So that they don't want you to double dip. The eligible time period for this includes a March 12th through January the 1st of 2020. However, it's based on your quarterly reimbursement. So to be an eligible employer for this, you have to demonstrate a decline in more than 50% on your quarterly gross receipts, or be able to demonstrate that you have partially suspended operations due to orders from an appropriate government authority. The maximum credit for this is $5,000 per employee per year. So when our company was looking at deciding whether to go with the PPP program or this, our maximum credit would have been $500. The PPP program offers us about $1 million. So we decided to go with the loan forgiveness program. Next slide, please. So this is just basically a review slide for future reference. It discusses employee rights for sick leave, and it talks about covered situations that your employers may use. Next slide, please. The Medicare advance payment, which you heard many of us mention and discuss, this is where for all eligible providers that bill Medicare, you can receive prepayment of your Medicare charges in an amount equal to 100 amount of your Medicare payments. And this is based off historic data for a 3-month period. So this is essentially a cash advance that you receive from Medicare in the form of a loan. Repayment is due at 120 days. Full repayment is due at 210 days. And the recoupment process for this is automatic. So after you reach the 120-day mark, when you bill Medicare, they automatically deduct it from your loan. The good thing about this program is it can be a very significant amount of money. For us, it was about $1.5 million. And that, again, is based off our historic Medicare billings. And the determination checks are issued very quickly. So according to the data on the CMS website, they're issued within 7 days of your application. Next slide. So, Lou, do you want me to go ahead and discuss?
Why don't you go through? There's a lot of questions about the nuts and bolts of how you charge and how you code for telehealth services.
Okay, so looking at virtual healthcare, there's basically 4 buckets. There's telehealth. You've got a virtual check-in, an e-visit, or telephone consult. So telehealth really took a step forward in 2019, but under the recent developments with the COVID virus, President Trump expanded these benefits using the waiver authority, the Coronavirus Preparedness Act, and the response supplemental approach. So what this did was two key things to COVID, to the telehealth utilization. First of all, the telehealth can now
we lost Eric there again, so we're going to go back to some questions. So here's a question for Jim. Jim, what arthroscopic sports medicine procedures do the panelists feel are urgent or emergent? Nick went over that a little bit. What is it for you?
Yeah, I think it would include for me in kind of the average Milwaukee patient, it would be limited in the need to something like a lock bucket handle tear that needs to be fixed. I think you can certainly make an argument that even a non-lock tear in someone who it's preventing him from going to work, I would consider an urgent case. So those would be kind of the obvious ones to me. ACL tears, I think I would probably consider in that almost urgent category under some circumstances.
All right, Eric, are you back up?
Lou, what if we hold off on this just because we're losing time and we provide the slides to the participants?
Sure, without a doubt. I just had a lot of value. I was hoping we could get it in. So, Brian, what procedures are you still doing in your surgery centers?
So I want to just a couple of quick things. There's 3 points that came up with the other speakers. One is this CMS advancement. We got notification within 2 days, and I'll believe when I see it, but we have $3.5 million coming to us, we hope, and obviously paid back. But this is significant money because it's all about retaining cash for operations. So we think that's a very good avenue to get immediate cash, even faster potentially than a credit line. Jim,
That's the Medicare advance payment.
That's correct. And Jim, I was interested, we looked at our burn rate per day, and initially it was about $300,000 per day, much of which was salary. And you indicated that you're keeping your salary staff. Now, you may have more hours. Our surgery centers are independent, but we're abiding by this urgent, time-sensitive concept, not emergent, because the hospital is emergent because of supply issues. They're reallocating all the operating rooms, but the biggest quandary right now is the independent surgery centers. What lens do we look through to make decisions? And if your hours are there for your employees, that's great. But I would argue that keeping a large payroll just because you're trying to be nice to your employees, you can be nice to them also by giving them their benefits, keeping those in place for the foreseeable future. And as long as they come back, this 7A loan is designed to maintain the payroll. So if you become cash poor because you're paying all your employees right now, I would argue that there's other strategies. I just wanted to put that out there.
And let me be clear, the surgery centers that we are affiliated with are separate entities. So when we're talking about the payroll, that's just for our office. So that has nothing to do with
fair enough. Yeah, fair enough.
And part of the reason that the surgery centers were still on a much more strict basis regarding surgery is the main surgery center, the most active one, is also co-owned by one of the local hospital systems. Yeah. And they look at that, therefore, as a possible source of both PPE and possible you need to use it as overflow.
Yeah. So Lou, to answer your question more specifically, what Jim is alluding to is most of our decision making is based on our local market. So if your situation is you're on top of a medical center that requires resources and they're still vertical on the curve, this is all based on the sustainability of the hospital system. So Nick is living in the middle of it. He's going to be generally far more restricted, but the overall mandate is essential services only. So unfortunately or fortunately, they've put restaurants and doctors in the same category for essential services. So I think that the way we're looking at this is as follows. If it's all the while we're protecting patient safety, staff safety, then none of that goes by the wayside. But the way we're thinking about it is if you're up on the curve and the curve starts to tip and there's no drain on additional resources that are outside the hospital system, you could argue that different markets will pick up at different times. The challenge is that none of us have been overwhelmingly prepared to make those decisions based on economic principles. We're still kind of reeling from the societal impact of this disease process. So, but much like other things in life, we think about, we've used this analogy before. There's a speed limit of 60 miles per hour. If we reduce that speed limit to 40 miles per hour, 20,000 fewer people will die. So we don't do that because economically it has a huge impact to go down to 40 miles per hour versus 60. We're not ready to make those decisions in this country based upon this. So what we're looking at is, as I say, we're sort of the S&P of our world is the hospital setting. If the hospital is running the risk of being overwhelmed, not sustained, then the definition of elective versus urgent versus time sensitive starts to morph. But believe me, New York, if New York turns the curve, I'd be hard pressed to say that they're going to be super concerned about what's going on in California. If New York's situation improves, demand and supply start to get matched and things get better, hospital services, more elective considerations will start to open up. So these are ethical discussions. They differ by market. They differ by how close you are to a hospital. And I would never be critical of anyone for the decisions they make of what they consider as elective, urgent, emergent, or time sensitive, because there's so many operational forces on this. So those are just some of my thoughts on it.
Right. So you're saying that there could be a diversity of what is and is not essential in different parts of the country based upon the impact of the pandemic.
That's my belief.
Correct. I would agree with that completely. So let's go with some other questions here. We're told that we may not use the PPP, the Paycheck Protection Program, for rent. Well, you can use it for rent.
You can definitely use it for rent. The calculation of the 2.5 is based solely on payroll, health insurance, and contributions to retirement. But then once you get the money, it is usable for rent. But 75% of it has to be used for payroll.
Correct. And how quickly do you need to rehire your staff if you take advantage of this program?
I believe it's June 30th. Is that correct, Eric?
So there is no defined rule that I have seen. So the verbiage that they use is that the staff should be rehired in a timely fashion. So I don't know that the regulators have come out with details on that at this date.
Yeah. So Eric, I have a question. So when Jim says we're maintaining our staff because we're going to get this loan, my argument is why don't maintain staff, because unemployment benefits are very, very generous right now if you don't need them. It's not that you're not being nice. So I'm trying to question that strategy. That's HR is 25% of our monthly burn is HR. And if people are sitting around doing nothing, I would find it difficult to keep them because they have good alternatives right now, but they're furloughed with every intention to bring them back online.
So we have decreased employee hours significantly. Our HR is referring patients to unemployment to take advantage of those benefits right now. Yeah. If we are approved and receive the funding from the PPP, we will then bring everybody back into house and we'll get them to 75% of their hours.
That's right.
That will be maintained for the 8-week period, and then we're going to have to reassess depending on what our volume's done.
Yeah.
But yeah, I agree with you. I think until you receive those funds, I would do the what's best to me.
Yeah. Pretend we're never going to see them.
Did you guys already cover the cash flow question?
Yeah, we did. But how about, Brian, how about access to line of credit too? You want to do that too. That's got to be strategy too.
Yeah. So, the good news is if you have most of us will have relationships with banks. So the first thing is you go to your bank that you have a good relationship with because they have every vested interest in your sustainability. So they also hopefully are a bank that is involved with this administering this 7A loan and forgiveness program. So they have a vested interest in administering that and giving you credit, hopefully, to keep and make ends meet. So the first thing we did was we said, look, we've got to get access to cash, whether we need it or not. Get access to cash. The good news, in my opinion, is the banks are solvent enough that you don't have to draw on it. You can leave it in the bank. There's a price to keep it there. They can allocate it aside. You'll pay a small fee for it, but you don't have to put it all in your bank account, because I would say, and I don't want to jinx anything, but it seems that the banks are in a good position right now, and the likelihood of them being unable to give you your line of credit is very, very low. I don't think, God willing, we're going to see a run on the banks here. But the line of credit is critical, and deal with the ones you have a relationship with, because they're the ones who have a vested interest in helping you get through this SBA 7A loan if that's what you're going to go for.
Right. So we've gone over a little bit, but that's okay. Let's try one more time. Just do the telehealth part. Just the telehealth part.
Am I coming in better now?
You are now. Yeah. So just try that. I think it's the next slide.
So please, we talked about the 4 different buckets of telehealth. So go back one slide, please. Telemedicine, first bucket. This is a synchronous service that occurs in real time with audio and video. You can use your traditional office visit code. So this is the to use every day for your E&M coding. 99201 to 205 for new patients, 99211 to 15 for established patients, a PIN to modifier 95, which essentially tells CMS that this is a telehealth code for office or outpatient services. The next code is a virtual check-in. These are G codes. They have really a very limited RVU value, but they can be used in some situations. The e-visit code, think about e-visit as an email code. The codes used for this are 99421 to 23. The RVU values are shown there, and for my market, the reimbursements are in parentheses. These are time-based codes, so it's 5 to 10 minutes, 10 to 20 minutes, or greater than 20 minutes, and you document your time. These three codes do have a global period of 7 days. So this means if you're going to use these codes, your email communication cannot initiate or proceed another billed E&M service by 7 days. And then your telephone codes, which are 9941, 441 to 43, and those are shown. Next slide, please. So I included 2 vignettes, and these are our office is doing the telemedicine and the e-visits. So the vignettes, I think, are important because they show you how you would document these in your EHR. Now, if you're already up and running with this, you probably are very familiar with this, but this is a vignette for a telemedicine code. So we would document in the EHR, and we have been using FaceTime, and we have been using Skype to use telemedicine. We find that some of our patients are very familiar with these platforms, and with a waiver of HIPAA compliance, readily utilizable software. So we would document in the EHR that we had an established patient that contacted the office, increasing knee pain. We would document that we used real-time audio and video and report a detailed history and review of systems. We would also report that minimal physical examination elements were performed, and you could ask the patient to demonstrate range of motion. You could look at the skin and document the evidence of any effusions. You document your diagnosis. So we have an established diagnosis of arthritis. This is a flare-up of arthritis. And then we document our recommendations. After the plan is discussed, you determine no office follow-up is recommended. And so this is not that G code. And then we document total time spent with the encounter. And so this will be a 99213-95. And the way that we've been working these into our office is we're doing callbacks with cancellations. So when we have patients that cancel, especially the Medicare population, we ask them if they are canceling due to concern of the coronavirus and if they would like to have a telemedicine visit as an option. We have a room set up, and so the physician works these in to their clinic flow. So you'll see real patient, real patient, real patient telemedicine. And we found that works pretty good. The documentation is done by an MA scribe right at our side. And I'm averaging 3 or 4 of these in any clinic day. Next slide, please. Forward, please. So the e-visits is another option that you should look at. An e-visit, think of this as an email. So what we would document here is that an established patient has contacted the office via a patient portal email for increased knee pain, the pain related to the diagnosis of moderate arthritis. Over a 7-day period, 3 email communications were sent to the patient. These emails are maintained, and many of the EHRs have the ability to do this. The emails are documented and retained. Total time period is 23 minutes, and you can generate a 99423 code and bill for that as well. Next slide, please. So I think this is a very useful slide. This is an algorithm that walks you through when to employ each of these individual codes. So if there's pictures and videos present, if it's real time, you're going to use your traditional E&M codes, and you're going to append a modifier 95. If the communication is determined that an office visit is necessary, you're going to use your virtual check-in or G codes. If it's an electronic email visit, you're going to use your 99421 or 23. And then if it's a telephone visit, you can use the 99411 through 43. But again, Medicare does not currently reimburse for these telephone visits.
Great. Thanks a lot, Eric. So we've run a couple minutes over. That's fine. There's a lot of information. I might want to do this again. This webinar is going to reside on the AANA website and will be, you can access it on the website. The slide deck will be on the website also. At this point in time, is there anything else that any of the other panelists would like to add for the attendees on the webinar?
I would like to say, Lou, to everyone here, our colleagues and our friends, I just want to wish everyone safety. I think it's a tough time. I want to wish everyone the importance of staying safe and taking this, I think, for what it really is in terms of a healthcare crisis. I mean, it is a healthcare crisis and an economic catastrophe, but I think first and foremost is the safety of people, patients, and your families and yourselves. So I think that's very important.
Thanks, Nick. All right. Well, with that, I'd like to thank the panelists for their time and for their dedication. And we may have to do this again, as this is a very fluid situation. Our best to you all. AANA wants your practice to succeed so that we can all go back to delivering the best high quality musculoskeletal care that we've been used to providing the patients in the United States of America. So good night from New York, and remains healthy, all of you. Thank you very much.
Thank you, Lou. Thanks for moderating this session. I think it was very educational and very helpful. And I also want to wish everybody to stay safe and maintain patient safety, your own safety, and safety of your family. Thank you, guys.
Good night.
Good night.
Thanks, everybody.
Good night.